Thank you for this opportunity to present to you some insights into the interpretation of endocrine laboratory tests. My name is Peter Graham and I work at the University of Nottingham in the United Kingdom. Here's just an example of an endocrine diagnostic test that we might have performed in a 9-year-old poodle with polyuria and polydipsia. Does this positive low-dose dexamethasone suppression test alone confirm that this animal has hyperadrenocorticism? This is the kind of decision that we have to make on a regular basis. What I hope to spend some time with you covering are some analytical considerations in interpretation with a little bit of physiology, some of the value of negative feedback, understanding how the endocrine systems work, some laboratory statistics, and then we'll look at some examples, interpretative approaches for adrenal disease in the case of hyperadrenocorticism, and investigating calcium disorders as another example of applying some interpretative principles. So the first thing I want to cover is whether or not we've got a good enough result to do our interpretation. So endocrine interpretations can be problematic enough, and if the quality of the result's not sufficient, then that's just going to make things more complicated. So we have to remember there are some analytical elements that we have to grasp. So for example, this is a package insert for a method that's designed to measure cortisol. And if we look at its cross-reactivity table, we can see that both prednisone and fludrocortisone will cross-react in this assay, which will cause high values, higher than are true because of cortisol presence, but are increased because of the presence of other related molecules like prednisone or fludrocortisone. In this assay, dexamethasone would not interfere. So just having some basic background to the kind of technology we're using gives us some idea as to whether or not a lab result would be believable. Certainly if an animal had just received prednisolone within the last day, measuring cortisol using this technique is going to give a misleadingly high result. Other things can interfere. The measurement of hormones almost exclusively depends on some kind of immunoassay. That means we're using antibodies in the lab to measure hormone concentrations. And if the animal brings their own antibodies, maybe in the form of something called heterophilic antibodies, or autoanalate antibodies, we'll talk about some thyroid hormone antibodies in a separate presentation. These will interfere and cause false results to be generated. And it's possible with some methods of analysis for us to have potential interference from things like icterus, lipemia, hemolysis. Some particular assays like FUT4 bioequilibrium dialysis has a positive interference. That means we get false high results when there's a lot of free fatty acids in the circulation. In some systems, the separator gel that we use in our serum tubes can have an impact on the measurement technique. And there's certainly quite a bit of variation between the measurement techniques and the laboratories that we use. This is the result of some work we did a couple of years ago looking at some dog thyroxine samples. We had 5 dogs thyroxine samples, 1, 2, pardon me, 3, 4, 5, at varying concentrations, some quite low, less than 10, up to somewhere in the much higher range. And we measured these 5 samples on 7 different methodologies, and you could see that we get quite a range of results depending on which analytical method we used. And the same when we've used similar studies looking at cortisol, we have quite a range of results here for cortisol. Depending on which method we use, each coloured line is a method measuring across the 9 samples, some very different to the rest. And in-clinic versions of cortisol assays performing very differently from those in reference labs. Again, an in-clinic analyzer performing a little bit differently from reference labs for progesterone, and one analyzer that was available to what we have in the UK called canine fertility clinics generating progesterone results that really bore no relationship to those generated by more traditional laboratory technologies. So understanding what method you use, what quality it is, whether it's any good, is helpful before starting to interpret our results. Here's an example from an external quality assurance scheme that's run by the European Society of Veterinary Endocrinology, and this is looking at insulin measurement. And what we discover is that a particular type of insulin methodology using a machine called Emulate in a commercial reference laboratory generates insulin results in, I think this is dogs, but it could easily be cats, which are undetectable or very low, whereas other methods are able to detect insulin. So this could pose a difficulty if we're trying to diagnose insulinoma, for example, in dogs, because this Emulate method would not be suitable. Another thing to be aware of is just the variation in results that we get between even reference laboratories, not just between in-clinic analyzers and reference labs, but between reference labs. This is, again, from the EQA scheme from the European Society of Veterinary Endocrinology, looking at the measurement of total thyroxine. We've sent a sample around the world to, in this case, around 60 laboratories, and they've each provided a result back for us to compare against one another. And although thyroxine is a very simple molecule and it's an identical molecule in every species, so we shouldn't really have any issue about different laboratory methods measuring it differently. What we discover is quite a range of results. So results here from less than 12.7 all the way up to 30 something, when the diagnostic cutoff value for hypothyroidism in the dog is probably going to be somewhere down here. So we've got quite a bit of crossover. And fructosamine, similarly, it's not a hormone, but we are interested in it in endocrinology to monitor this, how stable our diabetics are. And again, a really big range of results from in the high 200s up into the 500 or 600s, depending which laboratory we send our sample to. So it's very important to get to know your laboratory, understand the laboratory results it generates and how they relate to your patients. We sometimes say that local reference ranges will account for this, but when actually we tried to compare the local reference range provided by the labs and the results they were generating, we didn't find any linear relationship. So let's have a look at some other physiology. We've looked at the analytics. So what's negative feedback? Well, for us in endocrinology, it's the little bit that, for example, where we get our hormones like cortisol or thyroid hormone come back and tell the pituitary that they know it no longer needs to be secreting so much ACTH or TSH. And that negative feedback, what would we expect the body to be doing in different physiologic circumstances, is very helpful in interpretation. These are some diagrams taken from a veterinary endocrinology textbook from Utrecht. And we can see that where we have the exogenous administration of a medication, we're going to shut down pituitary secretion of our trophic hormone like ACTH or TSH, which is going to result in a reduction in size of our endocrine gland. Whereas if the endocrine gland itself fails, we lose the negative feedback, and so we start to see very big concentrations of our trophic hormone like TSH or ACTH. And if we have a failure of a pituitary gland to produce a trophic hormone, then we have a low value and low output. So these different combinations of the concentrations of our trophic hormone and our primary hormone can be very helpful in discovering what's going on. Other things that are going to have an impact on interpretation would include some physiologic factors like species. Some of our different methodologies that we use to measure hormones work better in some species than in others. So what our species is are going to give us so parathyroid hormone, for example, we can measure relatively well in dogs. In cats, I'm not sure that we do such a good job, and so we can't use feline PTH with quite the same confidence as we can use canine PTH. Age makes a difference. We might see, for example, total T4 concentrations tend to decline with age. TSH concentrations tend to increase with age. Very young animals have very high thyroid hormone concentrations. So there's a number of examples there where understanding a little bit about the age is going to help us. Also breed, again, thinking about a thyroid example, the sighthound breeds like the greyhounds and the Salukis, those kind of breeds tend to have much lower thyroid hormone concentrations than other breeds of dog. Although admittedly their T3 and TSH concentrations are pretty similar to other breeds, but total T4 and free T4 are much lower. Gender can obviously have a big difference in what we can expect of some of our steroid hormones, particularly those of gonadal origin, as clearly the reproductive cycle could make a difference too. Physiologic state is a very important concept that we come across in both thyroid and adrenal diagnostics. When animals are unwell for a non-endocrine reason, that does have an impact on their endocrine system. So for example, in dogs that are unwell for a non-thyroidal reason will often have a low thyroid hormone concentration. And similarly, dogs that are unwell for a non-adrenal reason will often have a high adrenal glucocorticoid output. Medications can make a big difference too. So physiology now, we've also got some sample and analytical, pre-analytical considerations to make. So some of our hormones are sensitive to how we ship them and whether we ship them cold or at room temperature, or if we are in an environment which has got quite high ambient temperatures, we can expect deterioration of things like ACTH and parathyroid hormone might decrease in transit. Something like free T4, on the other hand, might increase if it's warm in transit. So those are some kind of basic things we need to have in the back of our mind before putting a lot of effort in trying to understand what a particular result means for an animal. Does it mean it has an endocrine diagnosis or not? We have to have thought already about, was it shipped well? Was it analyzed well? Has it got a physiologic status that I need to consider in my interpretation? Has it had medication that might have impacted either the analytical technique or my interpretation of the result? So let's now look at some statistics of diagnostic test results. This relates to when we get a test result, how confidently we can believe what that result is telling us. Sometimes for some analytes, we can have a reference interval, and if the results are outside the reference interval, we can call them abnormal and perhaps associate them with a diagnosis. In other cases, particularly in endocrine diseases, we sometimes have our unaffected animals and our affected animals having some overlap of results somewhere in the middle, in which case we have to come up with, rather than a reference limit, which in this example here would be more than 150, we have to come up with some kind of cutoff value that helps us split those two populations out and then understand what the consequences for that are going to be with our false positive and false negative consequences. So let's just look at those definitions of sensitivity and specificity, diagnostic sensitivity and specificity. So if we were inventing a new test and we wanted to see how well it worked, we would get a group of animals that had the disease the test was designed to identify. And so, for example, let's imagine we had 100 of those animals, and if 89 of those gave a positive result, we would have a diagnostic sensitivity of 89%. And similarly, we'd find a group that didn't have the condition we were looking for and use our test in that group and check to see how many of those animals generated a negative result. That would give us diagnostic specificity. So if we maximize diagnostic sensitivity, that makes this number, the top number 99, very high, which makes the number underneath it, 1, very low. And where that number 1 is in the false negative box. That means our false negative rate with this test is going to be very low. If our false negative rate is going to be very low, that means when we get a negative result, we're going to be very much more likely to believe it. So high sensitivity tests are good for ruling out disease because false negatives are rare. Conversely, if we look at a specificity, a high specificity, say of 99%, that means we'll have very low false positives. If we've got very low false positives, that means most of our positives are going to be true. So we can have much more confidence in a positive result. So specificity increases our ability to rule in disease and confirm disease when it's there. So we believe the positive results in a high specificity test. There are some consequences to having tests that are not perfect, and unfortunately many of our endocrine tests are not perfect. The big issue that we tend to come across with thyroid and adrenal disease is having tests with bad diagnostic specificity. That is, we get false positive results from thyroxine or from low-dose dexamethasone suppression tests. And in endocrine diseases, bad specificity can be a concern because a disease like hypothyroidism or hyperadrenocorticism requires lifelong therapy. So we're putting animals on medication for the rest of their life, which they may not have needed if we've used a test with bad specificity, which many of our tests are. So let's just look at a couple of made-up examples of the impact of choosing the right animals to do our tests on. So here's an invented veterinarian who performs a low-dose dexamethasone suppression test whenever they come across an animal with high alkaline phosphatase. Now, I don't know what the prevalence of hyperadrenocorticism would be in that situation, but I would imagine it would be very low. So just for the purposes of working out these numbers, I've picked a prevalence value of 5%. And I'm going to use this 5% prevalence over, again, an imaginary number of 1,000 animals. With that 5% prevalence of 1,000 animals, that would mean that we had 50 diseased and 950 normal animals. And then I can go to the literature and find out what's been published about the low-dose dexamethasone suppression test for diagnostic sensitivity and specificity, and I can use this percentage. So 98% of 50 would be 49, and 73% of 950 would be 693. And I can fill in the other boxes just by subtraction. And what that allows me to do then is to see how many positives we would likely to see in this case. And in this case, we'd get around 694. Sorry, it allows me to see how many negatives we would have in this scenario. And we would have 694 negatives, of which 693 would genuinely be in the normal category of animal. So what's called our negative predictive value would be extremely high. We could believe negative results, which fits with what we've said. High sensitivity tests, we said, because they have a low false negative rate, means we've got very high confidence in our negative test results. When we look at positive predictive value, in this scenario, there'd be around 306 positive results generated, of which only 49 would really be from animals with hyperadrenocorticism. So our positive predictive value for hyperadrenocorticism is extremely low. And I'm sure if somebody tried to come and tell you a test for hyperadrenocorticism and told you it was a great test, because if you got a result, you could have 16% confidence that it really was truly positive, then that wouldn't be a test that you would choose to buy. This is an effect of the prevalence of the disease in the population that we're testing. So if, for example, we didn't test every dog with high alkaline phosphatase, but required them also to have a couple of relevant clinical signs for hyperadrenocorticism and also be old enough to fit with the signalment that's described in the literature. And we can fill in those same numbers, but in this case, let's say that by restricting which animals we're testing to those that seem more likely to have hyperadrenocorticism, we have increased our prevalence. So if we then do the same arithmetic using the same sensitivities and specificities from the literature, we can fill in all these numbers, and we can see that our negative predictive value is still very high. We can still believe the negative results that we generate, even when we are testing a high prevalence population. And we can believe much, much more, have much more confidence in the positive results now as well. It's still not great. We're only 78% sure that the results are genuinely indicating hyperadrenocorticism in a positive low-dose dexamethasone suppression test. But it's much better than the 16% we would have in the low prevalence situation. We can actually plot what happens to negative predictive value here in red, and what happens to positive predictive value here in blue across a range of prevalences listed across the bottom of this graphic. And we can see that if we wanted our positive predictive value to be greater than 90%, if we wanted to have greater than 90% confidence that a positive result really meant a dog had hyperadrenocorticism, then according to the data that's in the literature, we would already have to be more than 75% sure that we thought they had hyperadrenocorticism before we did the test. Okay, so let's look at some examples of applying these principles to hyperadrenocorticism diagnosis, and also just look at what some of the tests are available to us. So just a reminder of what's happening. We've got an axis here where the pituitary makes ACTH, stimulates cortisol production from the adrenal glands, which presents a negative feedback to the pituitary. Within the pituitary, there are a few different zones of the adrenal cortex. Within the adrenal cortex, there's a few different zones. There's the glomerulosa, the reticularis, and the fasciculata, and they've got differential responsibility for making different types of adrenal steroids, but all have their basis in cholesterol, and we have a series of enzymatic reactions that turn those into cortisol or aldosterone, or what we call the adrenal androgens. We can see that the drug Veteryl, trilostane, it has its action here at 3-beta-hydroxysteroid dehydrogenase. So that's trying to stop these earlier precursors being turned into cortisol. So when it comes to trying to make a diagnosis of hyperadrenocorticism, there are some physical features that we might be used to looking out for, like a pot belly, maybe a loss of muscle strength in the back, making a dip, maybe some alopecia, some calcinosis cutis, thin skin that's lost its elasticity. Animals with hyperadrenocorticism are also likely to have polyuria and polydipsia. So what are some of the difficulties that we face in interpretation when trying to think about a diagnosis of hyperadrenocorticism? The pitfalls that I think we see are an overdiagnosis, and that's to do with the poor diagnostic specificity of our adrenal tests, such as I explained in that low-dose dexamethasone suppression test example. This is made worse by non-adrenal illness. So again, as I mentioned a few slides ago, when animals are unwell for any reason, that's nothing to do with their adrenal function, the stress of that illness is going to cause some degree of adrenal hyperplasia. So we frequently get false positive test results, and we frequently get them in animals that are unwell for other reasons. And there are some other conditions that do have quite a lot of overlap in clinical signs. So there are a range of causes for vacuolar hepatopathies, which have physical presentations that look a little bit like hyperadrenocorticism, particularly with polyuria and polydipsia. And also some conditions like the hypertriglyceridemias can look a little bit like Cushing's disease or hyperadrenocorticism. And then the other thing I sometimes see working in laboratories is there's a desire to make a diagnosis of hyperadrenocorticism even when the lab results are telling you that it's not there. So in that example of working through the arithmetic, I demonstrated that if we get a negative low-dose dexamethasone suppression test result, we really should be pretty confident in that result. But I certainly see cases where, despite a negative low-dose dexamethasone suppression test result, clinicians are continuing to do more tests for hyperadrenocorticism. And we haven't really talked about it yet, but the low-dose dexamethasone suppression test, in addition to being able to tell whether an animal might have hyperadrenocorticism, can often also tell us whether that's got a pituitary or an adrenal source. And so sometimes I've seen cases where the low-dose dexamethasone suppression test is telling us both that, yep, hyperadrenocorticism is possible, and if it's there, it's pituitary dependent. And yet we still see later diagnostic tests trying to differentiate the source, even though we already know that the animal has a pituitary dependent origin. So those are our two questions, really, whenever we're looking at endocrine test results for hyperadrenocorticism. Number one is, do they support that diagnosis? And number two, do they help us decide between pituitary or adrenal dependent disease? So for trying to decide whether we have hyperadrenocorticism, do the clinical signs, or do we have laboratory results to support those clinical signs being hyperadrenocorticism? We've got the low-dose dexamethasone suppression test, the ACTH response or stimulation test, urine cortisol creatinine ratio. Not really used so much the steroid-induced alkaline phosphatase. And we can see that for diagnosis, the low-dose dexamethasone suppression test has been reported to have very high sensitivity, as has the urinary cortisol creatinine ratio. And that high sensitivity gives us a high confidence in negative result. That means it's very good for helping us rule out the disease. But the specificity for these tests have been reported to be quite low. And so we're less comfortable with a positive result definitely confirming the diagnosis. And with the ACTH stimulation, we might be a little bit more confident. When it comes to differentiating between pituitary and adrenal origin hyperadrenocorticism, the dexamethasone suppression tests, including the low-dose dex, can help us maybe about 60% of the time. And we have got endogenous ACTH as an option as well. So when should we be considering doing one of these tests for hyperadrenocorticism? I think it would be because of that impact on prevalence on our positive predictive value. We can only believe a positive predictive value with more than 90% confidence if we already had more than 75% belief that the disease was present before we did the test. And so we want to be in a position where we would believe a positive result if we had one. So we need some appropriate presenting signs. The animal needs to be old enough. We'd expect most dogs with elevated or excessive glucocorticoids to have an increase in their alkaline phosphatase and a decrease in their eosinophil count. And I think more and more we're starting to realize that we can't always use these diagnostic tests for a simple black and white yes/no answer. We have to use them as part of an overall judgment and recognizing that diagnosing hyperadrenocorticism is a judgment rather than a definite yes or no in many, many cases. It may be that we need to consider doing more than one set of tests or repeating the same tests after an extended interval. So maybe after 1 or 2 months of monitoring, we might need to do the tests again. And with some few exceptions, such as pulmonary thromboembolism, hyperadrenocorticism is not usually immediately life-threatening, so that gives us some time to work out whether we really have this disease, given that we're thinking about putting the animal on lifelong therapy if it does. And so sometimes it's worth sort of listing out the things that are supporting a diagnosis of hyperadrenocorticism and also the things that are making you consider that maybe it isn't hyperadrenocorticism, and also ranking them in some sense of how strongly they do that support. So there's quite a lot of things that would give us strong support to move us away from hyperadrenocorticism. There's not many things that give us very strong support to go towards hyperadrenocorticism, other than something like calcinosis cutis. So when it comes to those differentiating tests, we have the option of, if we've got pituitary dysfunction versus adrenal dysfunction, there should be a difference in endogenous ACTH concentrations. And this is the kind of pattern of results that we see when we've got adrenal dependent disease, as we would expect that through negative feedback is shutting down ACTH production. So we are getting generally low ACTH results when we have adrenal dependent hyperadrenocorticism. But when we've got pituitary dependent disease, we're not seeing that suppression. But given the reference interval that is generally supplied, the reference interval is a reference interval for healthy dogs. When we're using this endogenous ACTH, we're not testing healthy dogs. We're testing animals that we already think have hyperadrenocorticism, and we're trying to figure out which kind it has. So the reference interval is just kind of guidance so that you have some vague sense of what the numbers represent. But with pituitary-dependent disease, we can have results that are higher than the reference interval or within the reference interval, sometimes right down near the bottom of the reference interval, but not suppressed like we're seeing with these adrenal cases. So let's look through a few quick examples then of using these diagnostic tests. So here's a 9-year-old Cocker Spaniel, polyuric, polydipsic with some alopecia. A low-dose dexamethasone suppression test has been performed, and the result starts higher than the reference interval that's been provided, but we do get suppression at the 3 and 8 hour time point. So how might we interpret those results? Has this allowed us to rule out hyperadrenocorticism with a high degree of confidence, or are these clinical signs telling us that regardless of this being a normal result, we still want to think about it? So from my perspective, thinking back to what we said about the reported diagnostic sensitivity of this test, false negatives are rare. When we get a negative result, which this is, we look at that 8-hour result. Is it less than 30? Yes, it is. This is a negative result. We have high confidence in our negative results, so hyperadrenocorticism is ruled out. Here's a Schnauzer with calcinosis cutis. A low-dose dexamethasone suppression test has been performed. Starts a bit higher than their baseline reference interval. Comes down, not quite to the cutoff value, and then goes back up again. It is much higher than the cutoff value at 8 hours. So this does look like a positive result for hyperadrenocorticism. Has it helped us decide between pituitary or adrenal? Well, I think it has. And I think it has because if we had adrenal-dependent disease, remember that would have suppressed ACTH. So ACTH would already have been low, which would mean that when we put our dexamethasone injection in, it couldn't suppress ACTH any further, and so there would be no change in cortisol output. So if it was adrenal dependent disease, I would be expecting the result to stay quite high, to not really change from this 200 value. The fact that it has changed and that it's decreased by more than half of the baseline value gives me confidence that this positive result for hyperadrenocorticism supports a pituitary-dependent origin, because we've got this suppression down as far as 57. So I use that 50% rule of thumb. So 50% of 211 would be around 105. Do I get any results down here in the 3 to 8 hour period that are less than 105? Yes, I do. That helps me believe it's pituitary dependent. Here's one where not much has happened, and if anything's happened, it's the results seem to have increased. So that's telling us that the dexamethasone that we've administered has had no effect on pituitary production of ACTH. That could either be because it's already really low, like an adrenal-dependent form of the condition, or that the pituitary mass that's present is really resistant to dexamethasone. So we still have a possibility of either pituitary or adrenal in this case. And in this case, if we did an endogenous ACTH concentration, and we've got a reference interval there for guidance, what does that tell us? Well, based on that graphic that we looked at, where if it's very suppressed, it fits with adrenal, but if it's not very suppressed, it must be pituitary. So this result fits with pituitary-dependent disease. So just a reminder there of that diagram. So let's quickly look at some calcium disorders. Not something that everyone has to think about on a very regular basis, but we do see hypercalcemia in dogs and in cats. And those could be either due to a parathyroid process, usually a parathyroid adenoma, which we'd call primary hyperparathyroidism, or something else happening somewhere else in the animal that isn't the parathyroid gland that's causing calcium to be elevated. And that might be humoral hypercalcemia of malignancy, it might be vitamin D excess, it might be a granulomatous disease process, it might be bony lysis due to perhaps a neoplastic process or an inflammatory process. There's a kind of tedious disease known as feline idiopathic hypercalcemia, which we struggle to know very much about. And then we have some disorders that don't really fit the classic mechanisms that we have up here, like Addison's disease, raisin toxicity, and certain parasites. So when it comes to trying to figure out which category we have, we can measure parathyroid hormone and we can measure calcium. The calcium that we're interested in measuring is ionized calcium. Ionized calcium is the kind of calcium that the parathyroid gland is monitoring. The parathyroid gland doesn't monitor total calcium, it monitors ionized calcium. So what we want to see is whether the response to the parathyroid gland is making is appropriate to the level of calcium. So that's reaching back to that slide near the beginning of this presentation. We talked about understanding the impact of negative feedback. So if we have calcium that's coming from a lymphoma or some non-parathyroid origin, then that elevated calcium through negative feedback should be shutting down parathyroid hormone levels. And if parathyroid hormone concentrations are not being shut down, it suggests that there's some independent mechanism, that there's an adenoma within the parathyroid gland that's not responding to negative feedback. So both of these examples will have high ionized calcium. Either we'll have suppression or we won't have suppression, which will help split our parathyroid dependent and independent processes from each other diagnostically. And we can plot those in a kind of table here where we've got ionized calcium going in this along the bottom towards the right, and we've got parathyroid hormone going up the left towards the top. And where we have high ionized calcium concentrations but low parathyroid hormones, then that's a parathyroid independent process like hypercalcemia malignancy or vitamin D intoxication. Whereas if a high ionized calcium is failing to suppress PTH below normal, then it suggests we've got primary hyperparathyroidism. There is a bit of a gray zone here where we can't tell whether it's primary hyperparathyroidism or parathyroid independent, but you'll also notice there's an overlap against normal. So sometimes we'll see animals with high ionized calciums and normal parathyroid hormone results. The parathyroid hormone result might be normal, but it's not a normal situation because an animal with high ionized calcium should have its parathyroid hormone shut down if the parathyroid glands are working appropriately. So if we do have parathyroid hormone results that are in the normal range that have not been suppressed, and we have hypercalcemia, then that fits with primary hyperparathyroidism. When we've decided that we've got a parathyroid hormone independent process, then yep, we're looking at malignancies and vitamin D type conditions. The additional lab tests we might do in those situations would be perhaps parathyroid hormone related peptide, which is going to be present in a significant proportion of dogs that have got hypercalcemia of malignancy. Or we might want to measure vitamin D if we think there's a vitamin D intoxication. So even some big famous commercial providers of pet food sometimes get their dietary formulation incorrect and allow too much vitamin D into the diet and cause toxicities. So let's look at some case examples. Here's a golden retriever, quite an old golden retriever. We have got hypercalcemia, both total and ionized calcium are high, and parathyroid hormone concentration is high. So what do we think that is? Well, if we take our ionized calcium along the bottom of our little chart and go up our chart, we're in the primary hyperparathyroidism box. This is an animal that has high ionized calcium, but it's not shutting down parathyroid hormone. So it fits with primary hyperparathyroidism. Something like this, a parathyroid adenoma. Here's a Keeshond who also has high total and ionized calcium. Parathyroid hormone is in the reference interval. But if this animal had normal parathyroid function, that high calcium should be shutting down the parathyroid hormone production. The fact that it's not means that this is primary hyperparathyroidism. It's one of these results that's in this kind of shaded box on the right-hand part of this chart. Here's a golden retriever, high ionized calcium, low parathyroid hormone. So that's suggesting that we've got a source of high calcium that is being sensed by the parathyroid gland and it's shutting down its production. And in this case, it's PTHrP positive. So that's a hormone that's like parathyroid hormone that's secreted by some tumors. So being able to identify that in the blood confirms that this is humoral hypercalcemia of malignancy rather than some kind of vitamin D intoxication. Many tumors will produce PTHrP, but there are some other forms of hypercalcemia which are PTHrP negative. Probably such as this one, a young male golden retriever, hypercalcemic, really quite badly hypercalcemic, a low parathyroid hormone concentration, which tells us we've got parathyroid independent hypercalcemia, likely to be vitamin D or neoplasia. The PTHrP in this case hasn't helped us. So if they're negative, they don't help. If they're positive, they do tell us that we've got neoplasia. So not all the hypercalcemic cases, even when we've got something like a lymphoma, not all of them have got very high PTHrPs. All right, so in summary then, we've talked a little bit about the pre-interpretation and analytical considerations. What do we need to think about our lab result before we start putting too much interpretive thought into it? We've looked at predictive values and our confidence in the results, when we can be confident in a result. So our high sensitivity tests, we can be confident in the negatives. Our high specificity tests, we can be confident in the positives. We've looked at some adrenal tests and case examples. We haven't looked at thyroid in this set, but there is a separate presentation with some thyroid test discussion. And we've looked at some principles of parathyroid interpretation. So I hope you found this useful. That's my email address should you need to get in contact.